Welcome back to Metabolic Mind, where we're working to revolutionize the treatment of mental illness by providing information and resources at the intersection of metabolic health and mental health. I'm your host, Dr. Brett Scher. Today, I'm being joined by Dr. Cynthia Calkin. Now, Dr. Calkin is an associate professor in the Department of Psychiatry and the Department of Medical Neurosciences at Dalhousie University. I've mispronounced that so many times. Dalhousie University in Nova Scotia. Now, what's interesting about Cindy is that she started off as a family physician and transitioned into psychiatry. So in this episode, we're going to talk about that transition and why she did that, and actually how this helped her see this connection between metabolic health and mental health, and why that was such an important step. And now she's not just a clinician psychiatrist, which she certainly is, but she's also a researcher, and she's done some of the most impactful studies to really sort of help change this paradigm of psychiatry and say, wait a second, there is this dramatic connection between metabolic health and mental health, and treating metabolic dysfunction, treating insulin resistance can directly impact and improve the symptoms and lives of people living with mental illness. Now, in her case, specifically bipolar disorder. So her TRIO BD study was one of those really impactful studies that we're going to get into. So in this episode, we'll talk about the study, talk about the rationale behind it, talk about the findings, but most importantly, talk about what that means for this field of metabolic psychiatry, what this means for how she treats people and how people may want to look to be treated if they fit these certain criteria. So really, really impactful study, and just such a wonderful example of how research can impact clinical care kind of the very next day. But it hasn't been as smooth as she thought, right? It hasn't been so widely accepted. So we talk about why that is and if maybe it should be. So I hope you enjoy this interview with Dr. Cynthia Calkin. Well, Dr. Calkin, thanks so much for joining me today. It's a pleasure to have you on the Metabolic Mind podcast.
Thank you. It's my pleasure.
Now, I want to start with your history as a physician, because you are a psychiatrist at the University of Dalhousie. I got to get it right. Okay, Dalhousie. But you started off in family medicine and then transitioned into psychiatry. So I want to go back and sort of hear more about that transition and what it was in your practice that sort of led you to make that transition and what you've seen since you've done that.
Okay, well, I started off doing family medicine because I was really drawn to the concept of treating the whole patient. And whenever I thought of a specialty, I thought, I just can't focus on one body part because, you're talking about a person and everything is connected. And so that just didn't make sense to me. So I did family medicine for 10 years. When you're looking for psychiatric illness, you'll find that half of your patients have it if you're looking for it, and you ask and you recognize that some people who keep coming back with recurrent sleep problems and various other things, chronic pain, they actually have underlying psychiatric illness. I worked alongside an endocrinologist. I rented space from him, Bruce Wilson, in the Tri-Cities, Washington State, and he was sending me all kinds of his diabetic patients saying, I can't get good A1C control. This patient is depressed. Can you help treat the depression so we can get the A1C better and get the diabetes under better control? And so, this relationship between metabolism and psychiatric illness sort of goes back even to my family medicine days. After 10 years of practicing, doing family medicine, I was seeing more and more complex patients with very severe psychiatric illness. There weren't enough psychiatrists in the area, and I was very fortunate to have 2 or 3 psychiatrists who I could pick up the phone and call, and they would walk me through, how do you start lithium? How do you, what do you monitor? These things. And so I ended up doing a lot of psychiatry within my family medicine practice. And after 10 years of family medicine and seeing the top 20 problems again and again and again, you get very confident with that, but I needed a new challenge. And the really sick patients with psychiatric illness, I was still referring on to psychiatry, and I wanted to be the one to treat those patients. So I knew I needed to go back, do a residency in psychiatry. I was very focused at the time. I wanted specifically to see and treat patients with bipolar disorder. It was the disorder that fascinated me the most. You see 3 completely different people. When someone is well, they look a particular way. When they're manic, they look completely different. When they're depressed, they look like a completely different person. And I couldn't help what's going on in the brain that's doing this, that allows a patient to present this way. The other thing about going into psychiatry for me was psychiatric illness is where I saw the greatest suffering. And I did a lot of palliative care, and I was referred patients from oncology who had 3 months left to live, and I cared for them. I did house calls. But the greatest suffering I saw reported by patients was depression and psychiatric illness. And often they would have both. And they said the cancer was nothing, the depression is unbearable. And this is somewhere where I could make the greatest difference. If I could study psychiatry and really treat the sickest of the sick, then that was what I wanted to focus on.
That's so interesting to hear you say that, because I think within the medical community, we probably focus so much on heart disease and cancer, and that those are sort of the most common causes of death. And those are the things we focus on so much, and we think that cause the most suffering. But I think you're so right. I mean, there seems to be this disconnect, right, between psychiatry and the rest of medicine. But no, there isn't that disconnect. And that's what you found in your family practice, your family medicine practice, that then led you to psychiatry. And I think that's such a powerful example that you gave. And if the greatest cause of disability is psychiatric diagnosis, psychiatric condition. So I think you're right about being able to make the biggest impact. Now, not only have you made an impact by treating patients, but you've made an enormous impact with your research. And your research has really focused on the connection between metabolic disease and psychiatric illness, and how treating one can help the other. So before we get into the studies, which I want to get into because you've done a couple of fascinating studies, tell us the background of why you really wanted to focus on that area, because it is a bit of a paradigm shift in psychiatry. So what led you down that path?
Well, I think I was lucky that I wasn't sort of confined by the current paradigm. I've been one of those sort of people that I'm okay with thinking a bit differently, and I know that it's not always popular, but that's okay. I'm a bit of a loner that way, so it wasn't anything special. I don't have a research background. I don't have a PhD. I don't have, I'm a clinician, and I was being referred the sickest of the sick. Patients who had been ill for decades on, 8, 10 treatments that had failed. They come from all over the Maritime provinces, some from Ontario and Quebec. And they'd already seen 4 or 5 psychiatrists, and no one could get them better. And so I was the end of the line. And if I could not get these people better, then they weren't going to get better. And that was a very distressing notion for me when I started practicing and seeing one patient after another who was that sick. And that's what happens when you work in a tertiary center where you're highly subspecialized in a clinic that treats bipolar disorder only. And so one of the things, as a family doctor, I just can't change as a person because I've become a psychiatrist. And so I always was interested in what medical comorbid conditions the patients had. And what I saw was that there were really high rates of metabolic syndrome, really high rates of heart disease, stroke, obesity. So the first study I did as a resident was looking at obesity and outcomes in bipolar disorder. And we found that patients who were overweight had a partial response to lithium. Those who were obese had no response to lithium. And they also had patients who were overweight or obese had poor outcomes from a psychiatric standpoint. So it didn't make sense to me, why a patient would not respond to lithium because of their weight. It's not a fat-soluble drug. You titrate it to blood levels. I knew there was something more that I was missing that was impacting outcomes. And that's when I thought, it's sitting right in front of me. Well, what could it be? What could it be? And we knew about the high rates of type 2 diabetes, and we knew about the high rates of obesity. So what sits in between there that we don't test for? Insulin resistance. So in a way, it was right in front of me. It was kind of a no-brainer in a way. And then it was like, okay, well, I need to test for this. I need to systematically test for this. And what we found is that 54% of all patients with bipolar disorder have either type 2 diabetes or insulin resistance. And it is found at 3 times the rates compared to the general population. So very high metabolic dysregulation in our patients. And of those with type 2 diabetes in the cohort, I diagnosed 40% of them. So this is the other problem, is that this metabolic dysregulation is missed. It's fine that no one knew to test for insulin resistance, but we know about type 2 diabetes, and even that's missed. And patients tend not to present, and it's not something necessarily screened for in medicine, certainly not in Canada, where we're very, very conservative about screening type of tests that we do. And so, those who are already diabetic, well, they needed to be treated for their diabetes clearly, or it's a contributor to heart disease, brain disease, and whatnot. And those were the patients who had more chronic course of illness and poor response to mood stabilizing treatment. And so the logical question for me was, well, if we treat insulin resistance, then do we get the patients better? It made sense that insulin resistance, we know it affects the brain. So why would it not be affecting a brain disorder like bipolar disorder? And I don't think that the work that I've done is specific to bipolar disorder. I have specifically looked at bipolar disorder because these are the patients I work with. But we're now finding that we see it in treatment-resistant PTSD, treatment-resistant major depressive disorder, treatment-resistant OCD, generalized anxiety disorder. So I think it is something that we see in psychiatry, major psychiatric illness in general.
Yeah, there's so much there to discuss, because I love the way you describe that. But the way you sort of connect the dots between the increased prevalence of insulin resistance and type 2 diabetes and the thought that then we should probably treat it to see if we can better someone's mental health. It sounds so simple the way you say it, yet it's a complete paradigm shift to think that treating a metabolic condition is going to help the brain. That is a big paradigm shift within psychiatry. So I'm curious, when you started to go this route, were there people who thought, like, what are you doing? You can't do that. Like, treating insulin resistance isn't going to do it. It's a neurotransmitter problem, right? It's a brain problem. You need to treat the brain, not the body. Did you get that kind of pushback?
Yeah, I mean, yeah. A lot of people just kind of thought I was, crazy and off in left field. I was very fortunate. The Stanley Medical Research Institute, they leapt on this. I mean, some of it's how you write a grant, but I mean, when you tell the story, they found themselves the same place I found myself, which is leading to this question of, if we treat it, do we get people better? And it was so logical. And so it's not like I was coming up with some really esoteric kind of notion. I mean, if you walk down the path leading you to this question, it all made perfect sense. And yes, it might be a bit of a paradigm shift, but I mean, look what happened with peptic ulcer disease and H. pylori, bacterial infection of the gut. I mean, we used to think it was stress and whatnot caused ulcers. And then we realized that, no, it's actually an infection in the gut in many people that cause it. And if you don't treat the underlying infection, the patients don't get better. I view it very much in the same way. We need to go after looking for insulin resistance in every psychiatric patient. And then we need to go after treating it if they're unwell and not responding to usual psychotropic medications.
Now, people will say, though, look, not everybody with a psychiatric diagnosis has insulin resistance. So if it doesn't happen in everybody, how can it be the cause, right? That could be one sort of pushback. And how do you respond to that?
I don't think it's the cause of psychiatric illness per se. I get kids who come out of the child and adolescent system, and I test them. Some of them are insulin resistant right away, but many of them are not. They tend to develop it. So I have patients who maybe responded to lithium for 20 years, referred to as lithium responders, perfectly well, and then they hit their 40s and they stop responding to lithium. Other drugs are tried. Everything fails. And then they end up in my clinic, and then I test for insulin resistance, and they're insulin resistant. We treat the insulin resistance. That's how we get them better. So yeah, it's a paradigm shift, but I don't know that my view is that insulin resistance modifies the course of bipolar disorder. So we talk about this neuroprogressive form of bipolar disorder, which is the most severe form. It causes cognitive impairment, functional impairment as a result. And these patients tend not to go in remission. They're chronically unwell. They're very, very sick. And these are the kind of patients who end up in my office. And these are the patients we need to be, number one thing, thinking of insulin resistance and looking at potentially treating that. I think people should be screened from onset of diagnosis. And we may find that there are still higher rates of insulin resistance. And especially if people are on atypical antipsychotics, that's going to contribute. And I have to admit, I don't treat patients who have schizophrenia where you've got to use an antipsychotic to get them better. I do have some patients who have psychosis with mood episodes. And yes, I use an antipsychotic, but as soon as they're well, I get them off it because I know in the long term, it's going to contribute to this metabolic dysregulation and they're going to become worse. They're going to become chronically ill.
Yeah, that's sort of like this juxtaposition of it. The antipsychotics can be so beneficial, certainly in the acute phase, but they frequently will worsen insulin resistance. So not only does the patient become unhealthy from that standpoint, but it could be this feedback mechanism to then worsen their mental illness as well. So I guess that's what you were leading to, that's something you see regularly and therefore need to address the insulin resistance. But so now let's get into your study, because I think this is a great lead in to the TRIO-BD study, which is where you took patients with bipolar 1 or bipolar 2 and insulin resistance, and they were treatment resistant. So like you're saying, they're the sort of the sick of the sick, right? They've been tried on many different medications and haven't responded. And in 20 of them, you gave them metformin, and on 25 of them, you gave them placebo. So tell us about why you picked this population specifically to study and why you picked metformin.
Metformin is a cheap drug. We've had it 50, 60 years. It's safe. We even use it in pregnancy. It was a drug, there's a study looking at weight gain on olanzapine and using metformin and in the psychiatric literature. And I thought, there's no point in my using a drug there's no way psychiatrists are going to be willing to use. I mean, I really wanted to use semaglutide or liraglutide or one of these other drugs, but I just thought there's no way they're going to go for that. So let's go for something simple, cheap, accessible, affordable, and something that might actually get used. So that's how I chose metformin. In terms of, as a family doc, metformin would treat type 2 diabetes as a starting drug all of the time. And one of the things that really surprised me in the TRIO-BD study is that metformin only reversed insulin resistance 50% of the time. And so we started off with this as a metformin placebo, although our hypothesis was whether reversing insulin resistance would improve outcome. But we expected everyone in the metformin group would be, have their insulin resistance reversed. And we were blinded, the patients were blinded, the study assessors were blinded, the statistician was blinded, everyone was blinded. So it was one of these sort of gold standard studies in that regard. But the shocking thing for me was, it only worked 50% of the time. Once I learned that, I started using other mood sensitizers or insulin sensitizers like semaglutide, like pioglitazone in my mood and metabolism program. I work with an endocrinologist. We see the patients together and we sort of use what we need to, including diet, exercise, to get the insulin resistance turned around. But that was sort of, metformin was I was crossing my fingers that would be something that would be acceptable to people. But it's interesting because, now I'm taking a bit of time away from clinical work for a few months. And the same family doctors who referred me these patients who were so sick and wanted me to get them better, I don't know what they were thinking because what we currently were using wasn't working. So of course, we're going to come up with something new and something different and maybe something people aren't used to, but they're not willing to prescribe these drugs while I'm off. And it's really surprising because these drugs are drugs family doctors are incredibly comfortable with. But their sort of argument is, well, there's no indication to be doing this. And so I have to send them a copy of the TRIO-BD study, and say, yeah, there is actually. It would be really helpful if you did this, because what we find is if the patients come off or if they become insulin resistant again, they become sick again.
Yeah. Well, so I really want to get into that a little bit more about sort of the reaction to the trial and how it's changed or not changed practice. But first, let's get into the results. So you mentioned that metformin reversed insulin resistance in half the patients. So of the 20, 10 reversed their insulin resistance. And then you compared outcome measures for those who reversed their insulin resistance to those who didn't. So tell us what measures you used and what you found and what you think what the implications were for these patients.
Okay. Well, one thing I just wanted to add is one person in the placebo group reversed insulin resistance on their own. So they were kind of inspired by the study, and they started eating more protein throughout the day and decreased their simple carbohydrate intake and started exercising. So they managed to get their HOMA IR below 1.8. And so they were in that group of what we call converters. They converted to being insulin sensitive. So those who converted improved by week 6. And these are patients who'd been ill. The mean duration of illness was 25 years. And
25 years.
25 years.
And they improved within 6 weeks.
Yes. And almost
Wow.
90% of those had not had a remission in those 25 years.
Wow.
They had come to us on average on 2 to 3 failed drugs that they were currently on, failed psychotropic drugs. They'd failed 8 or 9 psychotropic drugs in their lifetime, including things like psychotherapies, CBT, and things like that. So this was really, truly a treatment-resistant population. We didn't go into it insisting they be treatment-resistant, and I don't know why. I didn't think of it ahead of time, because when I look back to our outcome study, it was the patients who had comorbid insulin resistance who were the really, really sick patients. So we had an entrance criteria of a MADRS, or Montgomery-Åsberg Depression Rating Scale score of 15, but the mean MADRS coming in was 28, which is moderate to markedly depressed. So much more, severe depression for a much longer duration. They had to be in a depression, failing current medications for 4 weeks, and they had come to me on these drugs for months or years. And way more depressed. So we saw this improvement in MADRS, and our effect sizes for just about every measure was above 1, which is a very, very big effect size we never see in psychiatry. And we looked at HAM-A, so their anxiety improved over the 26-week period. We used 14 weeks as our sort of primary outcome endpoint, and then we followed patients through just to see what happened sort of in the intermediate term, whether patients remained well or not. And that was the case for MADRS, so depression, HAM-A, anxiety, global assessment of functioning, so their overall ability to function. The CGI-BP, which is a clinical global impression, overall, based on clinical experience, has the patient improved or not improved? And it's very hard to see those numbers budge, but we did see improvement in that. We saw reduction in suicide. We had no emergence of mania. And so, it looks like a very safe, rapid way to get people better. And I think it's because it's mechanism driven, like we're going after an underlying aberrant mechanism and we're sort of correcting that. And that's why people are getting better faster. Now the first fellow coming out of Trio BD was sure he was on placebo. And none of us knew, of course, and I couldn't unblind till we were through the study, but he really, really wanted to be given metformin. And because he didn't respond in the study, I said, why not? He had tried everything else, and he'd been sick for 5-6 years in this depressive episode, and he got better within 6 weeks on metformin. He's been on it now almost 7 years, and he's remained in remission the whole time.
Yeah. So you used a whole bunch of different scores, and the average person, or even the average physician who's not a psychiatrist, isn't going to know what they mean. And if a score increases or decreases by a few points, what does it really mean? But I think it's important to emphasize that this really was a significant change in quality of life for these individuals. It wasn't just a mild change in score. And is that something that is now sort of being recognized by psychiatrists, by doctors in this field, to say, wow, that's a really significant result by using metformin, something we don't usually use to treat bipolar disorder. So this is something I need to take note of. Is that the reaction you've seen? Because I'm sure that's the reaction we would all hope for with a study like this.
It's been very slow to catch on. And I think that anything where there's a paradigm shift that changes your field in the way that maybe we conceptualize psychiatry, that's slow to catch on. And we're asking people who have been away from, you discussed earlier how psychiatry is sort of out on its own in the rest of medicine. And I constantly am saying, psychiatry is a subspecialty of medicine, to try and bring people back to that. But I think that it's challenging for people who have been out doing psychiatry for a number of decades to ask them to be thinking medically again and to be treating the whole patient and to be using drugs that they're unfamiliar with. I think it's going to take time. Now, patients are on it, and patients are petrified, because currently here where I'm living, I'm the only one, prescribing these drugs. The family doctors won't do it because they believe there's no indication. Other psychiatrists won't do it. I've heard from family doctors who tell me that other people in mood disorders recommend metformin, but they want the family doctor to prescribe it, and then they won't because they don't know what the indication is. So I'm trying to get the Trio BD study paper out there. I had paid to have it open access, so it's free to anyone around the world. People who live in countries where it costs a month's salary to normally purchase a paper, a report, a study like that. I wanted it accessible to everyone, patients and clinicians around the world. So it should be accessible for people. But again, I think anything where there's a paradigm shift, it's going to take time. And I feel the sense of urgency because I see these really sick patients and I see them get better rapidly with this type of treatment. And so, of course, I want everybody doing it. The more patients, the better. And then the more patients who can be referred to me, the better, because we'll get them on this treatment. The patients are completely sold on it because they've been sick for so long and they're finally better. And the quality of remission is different. So they'll tell me that this is as well as they felt prior to them developing bipolar disorder. So they've never had this quality of remission with any other treatment. And so that's really interesting to me too, because I think we're getting at this sort of metabolic dysregulation in the body that's affecting the brain. And so if you can figure out these mechanisms, and I think blood-brain barrier leakage is another one of these mechanisms, possibly related to insulin resistance, or at least insulin resistance may be a contributing factor. But there's ways we can use vascular protective agents or drugs to repair the blood-brain barrier potentially. So now we have these mechanisms where we can go after insulin resistance with multiple different treatments and strategies like diet and exercise. We can go after repairing blood-brain barrier with drugs like telmisartan, losartan. The studies need to be done, like, formal studies, large studies, multi-center and whatnot. But as a physician, you can justify what you're doing. If you have a rationale and you can justify what you're doing. So if someone has high blood pressure, I'm going to choose telmisartan. And as a family doctor, I'm comfortable, prescribing these drugs. I haven't done family medicine in a number of years, but I've maintained my credential and I continue to stay on top of this stuff. I just wish I could convince more people. I do have residents who choose to work with me for electives, but coming through mood disorders is not, or the mood metabolism program that I run, it's not part of the core program. And when I look at how impactful it is in terms of psychiatric illness in general, I've sort of put forth to our program that I really think it needs to be they need to come and spend a couple of months at least to learn how to test for insulin resistance, how to use the different drugs, and to actually witness the improvement. Once you see that, then you understand that what it is you're doing, this is clearly what you need to be doing.
Yeah. So I want to get into a little bit more about the blood-brain barrier and then, of course, talk about other things we can do to treat insulin resistance besides metformin. But just a quick mention about the high blood pressure. I mean, I remember when being treated or when being taught how to treat high blood pressure, one aspect is you look for other things that are going on. So if the patient has kidney disease, then you pick a certain class of medication. If they have heart disease, you pick a certain class. If they have migraines, you pick a certain class. So you can kind of get more bang for your buck, so to speak, with your high blood pressure medicine. But never, ever was it mentioned if they have a psychiatric illness that you pick a certain kind. That was never discussed, but that's so interesting to hear you bring up. But now you've brought up the blood-brain barrier. So the blood-brain barrier is just a normal thing we have in our body that prevents, I guess you could say, toxins or inflammatory markers or even sort of infections from going from your blood into your brain. It's a normal barrier, blood-brain barrier. So what you found in one of your studies was that the worse the insulin resistance, the more leakage there was in this blood-brain barrier, and then that correlated to the degree of bipolar symptoms. So tell us about sort of the implications of this study and how that also was sort of a revolutionary new finding.
Yeah, I just want to make one small distinction that's a little bit different from how you worded it.
Oh, please. Yeah.
Yeah. So
I guess you did the study. I should probably let you explain it instead of me trying to explain it. Yeah.
What you explained is what I was expecting to find. But what we found was that patients with bipolar disorder and extensive blood-brain barrier leakage, they were a certain sort of phenotype. The patients that had normal blood-brain barrier permeability were a very heterogeneous group. Some had bipolar disorder with insulin resistance, some had bipolar without insulin resistance, some were healthy controls, some were insulin-resistant controls. But the group that had extensive leakage, they were all bipolar patients with insulin resistance. So they had worse metabolic parameters, they had higher body mass indices, they had older heart age on Framingham scores. We looked at some heart markers. They had higher scores on the depression and anxiety rating scale, so more severe depression, anxiety, and poor overall functioning. And when we looked at their course of illness, they had a chronic course that tended to be treatment resistant. And so I think that blood-brain barrier leakage is a marker for more severe psychiatric illness, that insulin resistance contributes to that severity. Now, why some bipolar patients with insulin resistance didn't have extensive blood-brain barrier leakage might have to do with the severity of insulin resistance, the duration of insulin resistance. We're not sure. It might, and there may be other factors that we need to still learn about that are contributing to that. But what we have seen, the first patient that I told you wanted to be on metformin coming out of the Triage study, we imaged his brain before and after treatment with metformin, blood-brain barrier imaging with dynamic contrast enhanced using gadolinium. He had extensive blood-brain barrier leakage. He had severe depression on the MADRS scale, and he was insulin resistant. 12, 14 weeks later, he was no longer insulin resistant. His blood-brain barrier had completely healed, and his depression remitted for the first time in 5 years. And so it's really powerful. And recently, a colleague sent me a treatment-resistant patient with PTSD. And he said to me, well, should I test for insulin resistance? And I said, yeah, sure, why not? And so he did, and he was insulin resistant. And he said, I don't know what to do. Like there's no study, there's no precedence. I said, you know what? Based on the bipolar study, let's just apply this now to other psychiatric illness. Go ahead and treat him with metformin. It's safe. Explain to him this is off-label, like most things we use in psychiatry. Explain the risks and benefits. Patient was more than happy. He was very interested in research, so he wanted his brain scanned. And we did the same thing. And he had extensive leakage. He was insulin resistant. And he had very high scores in terms of the PTSD rating scales. And again, 12, 14 weeks later, blood-brain barrier healed, no longer insulin resistant, and he's well. So it's really powerful. And it's not like this is 1 out of 10 patients. This is the very first bipolar patient we looked at, the very first patient with PTSD we've looked at. And so I suspect we'll see it with the first treatment-resistant GAD patient or the first treatment-resistant patient with OCD. I think we're going to see this with all major psychiatric illness.
Yeah, that is so fascinating because of the DSM criteria of how psychiatric illnesses are diagnosed and coded, we think of them as separate buckets. Bipolar is different from depression, is different from schizophrenia, is different from anxiety, is different from PTSD, but not necessarily, right? They're all sort of like on the same spectrum, and this brings up a potential mechanism for how that could be. Maybe it has something to do with the blood-brain barrier. Maybe it has something to do with insulin resistance unifying these diagnoses, and that's why treatments for one can help treatments for another. And that's sort of another concept that I think is maybe a little foreign, is that you can have one treatment for many different disorders. And so that leads me to talking about what we can do to treat insulin resistance. I mean, we've spent a lot of time talking about metformin because that's what you used in your study. But as you said, it worked in 50% of the subjects in the trial BD study. And we don't want to just help 50% of the patients, right? So there are other things that we can do. So what do you see as the other interventions that we can and maybe should be doing for people with mental illness and insulin resistance?
Yeah, so what I do in my program is they get a trial of 12 weeks or so, or even 8 weeks on metformin. And if they don't respond to that, because we know from the TRIO-BD study, they should be responding by 6 weeks. 8, 10 weeks is plenty of time if they're not responding. Or if they get a partial response and their HOMA-IR comes down partly, then we have been adding semaglutide. So that's the once weekly injectable that you slowly increase the dosage. It typically reverses insulin resistance through weight loss. And so obesity, which is a medical term, body mass index above 30, that is the sort of the mean body mass index in patients in the clinic. And so they really struggle with their weight. And once you're insulin resistant, it's very difficult to lose weight. And so using a drug like semaglutide, they may lose 40 pounds and it will reverse the insulin resistance that way. So I've been able to get another 50% of patients better using semaglutide. Then I'm left with 25% that I haven't gotten better. And we've started to use pioglitazone. And in a couple of those patients for whom none of these drugs have reversed their insulin resistance and they've remained insulin resistant, if they have extensive blood-brain barrier leakage, we're looking to use telmisartan as another medication as their blood pressure tolerates to see if we can heal the blood-brain barrier leakage and get them better that way.
Now, using epilepsy as an example, the patients who have treatment-resistant seizures with epilepsy are frequently tried on a number of different medications in a certain order. And then if they're not responding, then they can be prescribed a ketogenic diet. So then the focus is on lifestyle. And there's, I guess, a frustration, you could say, within the metabolic health community that why is nutrition and lifestyle reserved for treatment failures or treatment-resistant patients? So when you approach a patient and you've listed a number of different medications which have specific uses and which seem like they are benefiting the patients in this subset, how do you address lifestyle with them in addition to the medications?
Yeah, so, in family medicine, when I was treating things like type 2 diabetes, we start with diet and exercise before starting medications. Typically, the patients that I treat are so sick, they can barely go from the bed to the couch. So in terms of focusing on diet, they may order a pizza once a day that comes to their door, and that's all they can manage. And this is why we chose, otherwise it's sort of like, yeah, diet and exercise would be the mainstay for me in terms of the initial approach, but they're too sick for that initial approach. So what we do is we get them onto metformin, in 6 weeks, they're feeling significantly better. Then we start talking about diet and exercise. And this is where I think adding ketogenic diet potentially might be something. And it could be that then ketogenic diet and lifestyle change, the increase in exercise, because exercise also helps mood in addition to things like insulin resistance. Maybe patients could stay well with that. And maybe they could even be tapered off the metabolic drugs like metformin. The difficulty that we see with metabolic dysregulation is it tends to march on over time. And I think in a lot of ways that's genetic. And so we can stave off the development of type 2 diabetes with diet, exercise, things like metformin and other medications. But eventually people often need 2 medications for their diabetes or 3 medications, and some end up on insulin for type 2 diabetes. And some, and it's not the patient's fault. This is one of the things that happens. I had patients who were diet treated type 2 diabetics for, 10 years, perfect A1C. And then all of a sudden they start needing a bit of metformin, and it wasn't due to change in their diet. They were doing nothing wrong. It's just that part of this metabolic dysregulation, I think, is genetic.
Yeah. I think that's a really interesting point you bring up, though, about the timing of nutritional intervention. I've interviewed a number of people who have had success with ketogenic diets for their mental illness. But I think it's clear you need a lot of support and you need to be open to it and in a place where you can implement it, certainly in the beginning. And so I think that's a really important picture that you sort of drew, that like they may just be sitting at home ordering a pizza once a day. That's all they can do. That person doesn't have the support and doesn't have the ability to really upend their whole nutrition. But 6 weeks later, you're dealing with a whole new person. And that's what I think is a good marker for someone like you who has this experience, who knows the stepwise approach, who knows when the right time to approach somebody to discuss a nutrition intervention might be. So have you seen patients adopt a ketogenic diet, and have you seen that significantly improve their symptoms as well, above and beyond what the medications have done?
I haven't seen, I've discussed this with Tom Ransom, who's the endocrinologist who works in the mood metabolism program with me. And prior to studying medicine, he was a dietitian and nutritionist. And, he was saying to me that there's no specific sort of ketogenic diet. Like one of the things that might be helpful is that there was something specific to prescribe. But he does sort of dietary intervention, which I think sort of parallels the ketogenic diet somewhat in terms of increasing the protein, decreasing the simple carbohydrates, but it's not in a structured fashion. And I think what would help us in our program would be for us to adopt a structured program that could provide the support that people need to implement something like the ketogenic diet and see how that works for them in terms of, and it may be that we can get rid of some of the drugs. I think it's difficult to treat at least the kind of patients that I see and treat. I think that they're probably always going to need a mood stabilizer, but that being able to manage the metabolic dysregulation, the healthiest way, of course, I think, is diet and exercise if you can, like for heart disease, for diabetes, for, any of these things, high blood pressure, dyslipidemia, diet and exercise would be the mainstay approach. So I think that would be something, because I think people need support in direction and structure. And so this is something that would be really helpful for us to be able to add that kind of support and whatnot. And I think Tom is open to it in terms of, okay, how might we incorporate this into part of the treatment regime? And then potentially, it's like treating type 2 diabetes as well. You use medications, but once people have their A1C under control, sometimes you can back off the meds because they've been able to then make the dietary change. And it needs to be a lifestyle change, not sort of going on a diet per se. I think it's a mindset where it's a lifestyle change in terms of, it's something you have to maintain and it has to be doable for you.
Yeah, and such a good point about the combination of medications and lifestyle. And, with type 2 diabetes, you can go off your diabetes medications, and then your blood sugar might start creeping up if you need your medications again. But with bipolar, you may end up manic and psychotic in the hospital, so that you have to be much more careful from that standpoint. And that's why we always talk about nutrition as an additional intervention, as an additional treatment with conventional medications. And sure, deprescription or reducing doses may be possible in the future, but certainly in the beginning, definitely not recommended. And I think that's a really important point you brought up. Now, you sort of alluded to this before, but the adoption with one paper like this for something that changes a paradigm is slow. So what do you hope to see in the future? What do you think it will take in the future to get this, more commonly adopted for people to realize, yes, this is something relatively simple and relatively effective I can do with some very sick patients who need help?
Well, I have some patients who sort of volunteered to act as spokespeople sort of for this type of research. And one patient, I know she won't mind my saying because she's very sort of vocal. She's been on television with me on CBC News in Canada, Kelly, who talks about her experience and coming through the Triobd study. She did respond. And how it's just completely changed her life. Like she's got her life back, and it's not just her life back, but it's even better, and I think that's really powerful. And I think in a lot of ways, we listen to patients, and we should, they're the ones who tell us what helps them and what doesn't. And so I'm really hoping that the more patients talk about it, and I'll have family doctors call me and say, I see this patient of yours, and I know you do this thing with metformin, and he's been really well ever since. And I have another patient who has psychiatric illness. What's your opinion on that? And what should I do? And, so I'm trying to get them to test, do HOMA-IRs and look for insulin resistance and just trying to support them. But I'm sort of one person, So this sort of metabolic group that's now starting to come together with the help of the Bozuki family, I think this is really helpful because it's way more powerful than, one person in my little corner of the world trying to slowly make these changes. With this one study, I have some colleagues who are hoping to get funding to replicate the TRIO study and to add a few sort of other tests to look at mechanism more deeply, I think that will be great. Our outcome study was replicated, and then that really helped in terms of people starting to realize that metabolic dysregulation has an impact on psychiatric clinical outcomes. But yeah, so replication would help. I do talks with family docs because I really thought I could get family docs on side easier than I could get the psychiatrists on side. And I talked to the young psychiatrists, and a lot of them, they have to do research projects as part of their program. And a lot of them, I teach R2s. I give lecture to R2s, and I talk about metabolic psychiatry with them. They're close enough to their medical training that they're sort of more accepting of it. And they think it's kind of cool to, wow, there is this underlying thing we can go after. And so I'm hoping that as they graduate, they will be incorporating it into their practice. But again, it's not kind of a core part of our program to have residents come through and learn about metabolic psychiatry. Yet it's this sort of, I think, massive kind of new approach based on better understanding of mechanisms underlying severe psychiatric illness.
Yeah, well, goodness, thank you for all the work you've done to try and change this and try and move this field forward and present the different hypotheses that people really should sit up and take note of and do further studies, like you're saying, and start incorporating it into their treatment practice. But it takes education, because the needle tends to move slowly. But you're doing fantastic work to help move that needle. So thank you so much for all your work, and thanks for joining us today on Metabolic Mind.
Well, thank you. And I hope that this will help in terms of your listeners. And maybe if any of them are patients, we'll talk to their doctors and take them a copy of the TRIO paper. That's what I tell people. Yes. Arm yourself with this paper. You can access it and take it with you. And, often it's the first time the doctor's seen it. Family doctors in particular are super busy, So being able to maybe see that, it'll change and change slowly, I hope.
Thank you for joining us on the Metabolic Mind podcast. Now, please remember, though, our channel is for informational purposes only. We're not providing individual or group or medical or healthcare advice or establishing a provider-patient relationship. Many of the interventions we discuss can have dramatic or potentially dangerous effects if done without proper supervision. Consult your healthcare provider before changing your lifestyle or your medications. And please join us again next time on the Metabolic Mind podcast, where we will explore more about this connection between metabolic health and mental health and metabolic therapy as mental health therapies. Together, we can help change the face of psychiatry and help so many people who are looking for help find information and resources that may help them on their path to wellness.